Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you for the organizing committee and settling committee to have me here, and thank you, Dr. Majid, for this nice introduction. My talk today about prevention of intraventricular hemorrhage IVH in a preterm infant. I have nothing to disclose related to this presentation. The content will be epidemiology, timing and grading, risk factors, and I'm going to concentrate on coagulopathy and head position. And if we have time, I'm going to show you the 7 predictive scores that are available in literature. As you know, the germinal, the subependymal germinal matrix, this is the origin of IVH. And because it's very delicate, they start the bleeding there. And why the gestational age, why the older gestational age has less IVH? Because this area is regressed with the time, as the slide shows. The risk of IVH worldwide between 20 to 25 in babies less than 1.5 grams, 1.5 kilograms. All of us, we know that IVH occurs in first 3 days to 5 days. But if you focus closely on this time interval, it actually 50% of IVH will occur between 6 to 12 hours of age. We did meta-analysis and confirm our perception that 50 to 48% of the IVH within 6 hours of life. The good thing, 3 studies after our publication confirm that. One of them is the PNAT trial, the preterm erythromycin neuroprotection study. They screen the babies before the enrollment in their study, and 56 of their IVH occur within 12 hours of life. So we have a good evidence that at least half of the IVH in the first 6 to 12 hours of life. What is the implication of this piece of information or piece of data? First, you need to decide when you need to screen the head ultrasound. We know European countries, they screen head ultrasound first a few hours of life, whereas in North America, they will do it late at 5 to 7 days. Now, even North America people, including Volpe, they start to move toward early screening. And because maybe the European country, the neonatologists themselves, they are doing head ultrasound, as Dr. Majid taught us when we were resident, so maybe they are more keen to do it early. The other important piece of information is appraising clinical research. If we know that most of the IVH, or 50%, occurs very shortly after birth, then any retrospective study looking about the risk factor of IVH, that will be not accurate, because most of the factor will occur after this time period. Now, regarding the prevention, we need to prevent early IVH. So we need to start our prevention very early in the life, maybe even before deliveries. Now, the other thing, it depends on you and situation and the parent. If you are happy to keep the secret of IVH until 7 days of life, I think it's difficult sometimes to accept by parent. You are assuring the parent that everything is okay and baby is doing fine, has been extubated. Then suddenly at 7 days of life, you have something in ultrasound, grade 2 or 3, then the life will be difficult. So sometimes we find it very difficult to wait until 7 days of life, then we tell the parent about IVH. The other important issue in IVH is grading. We know the 2 famous grading systems, Papil and Volpe, and all of us, we know what's mean of this. But since 2003, people start to heavily criticize this scoring. And one of the problem with this scoring, they are not taking account in the bilaterality. And we know that 25 to 33% of IVH could be bilateral. And also the midline shift and extensive of IVH has been linked to the bad neurological outcome. And this score will not take account. For that reason, all the studies, they will deal with bilateral IVH or severe IVH as unilateral one. So because of this idea, we came with the idea about IVH scoring, which is very simply, we try to give any IVH event a different discriminated score. And we did that by simple mathematical things. We squared the score of Papil. For example, if the patient has IVH grade 2, we score that grade 2, it will be 4. And we added the score on the other side, and if there is extensive, we add 5 extra point. The 5, we chose it arbitrarily. You might tune that score if you would like, because a new PAT study, they use a different category of the severe IVH. Our score will extend from 0, what means normal, to 35, the most extensive one. Luckily, this score was externally validated in Calgary. They compare between Papil and our score. The area under the curve almost the same. Really, the B value is 0.04, but it's not accounting for that significant. But the good thing, we found that score 5, which means baby with one side grade 2, another side grade 1, and 6 with what's mean baby with bilateral grade 2, the specificity of a neurological outcome is much, much better than Papil. Now, what is the importance of knowing the severity score? When you targeting to prevent IVH, you need to decrease the rate of IVH. You need also to decrease the severity. The classical teaching for pathogenesis is breakdown into 3 categories: intravascular, vascular, and extravascular. And each category has its own risk factors. If I want to enumerate risk factors, it's easy to enumerate them. Gestational age, birth weight, we know that if the baby born less than 28 weeks, the baby will be at risk more than 28 weeks. Birth weight, the same thing. Male, antenatal steroid. So there is a lot of factors we can enumerate. But the story is not that simple. The story is like this. If you, Dr. Al-Haddad recently published a paper, and he tried to link the risk factor together by using direct cyclic graph, and they built 370 relationships. So if you want to prevent IVH, it is really like this map. It's very difficult, and then the factors interact with each other. Here also, they try to classify the factors according to the evidence-based, and as you see, the color all over the places. So what can we do, and how can we prevent IVH? All of us, we know antenatal steroid. This is the most important factors, and we know it's recommended between 24 to 33 plus 6 days, and not considered or not recommended below that age, and maybe recommended after 34 weeks, provided the risk of delivery will be within 7 days. But recently we have 2 studies that make our life is not easy as we thought. Before, we need only to think what the gestation age we need to give steroid. But these 2 studies showed that if we give steroid to premature babies, that is indicated to receive steroid, but the baby likely will not be delivered prematurely and deliver at term, their neurological outcome was not good as full-term baby that received no steroid. So these 2 studies raised a red flag that we need to be sure that delivery is imminent or baby will be delivered. If not, then we might jeopardize their career. The other thing, and I'm sure Dr. Muhammad Al-Hindi will explain more about this, delayed cord clamping. Delayed cord clamping, in meta-analysis, we have evidence regarding IVH that can prevent IVH, but not severe IVH, only all the grade. Now, a little bit from statistics. We know before we look to the p-value only, and if it's significant, we are happy. We look to the confidence interval. If it is narrow and doesn't cross 1, we are happy. Now the grade now, to move from that classical teaching, then they want now to present the data with the size of effect and the accuracy, and not to put much weight on the statistical significance. So if I use this, then I would say delayed cord clamping may result in little to no difference in severe IVH. And I will say delayed cord clamping reduce any grade of IVH slightly. Now the problem with delayed cord clamp is not only the research or the statistical, the feasibility is very difficult. It's not easy. I don't remember that we have babies less than 27 weeks that we could delete cord clamping to 30 seconds, because everybody rush to get the baby stabilized. And in HD data, only 30% of babies less than 28 weeks get the delayed cord clamping. Maybe Dr. Al-Hindi will help us today how to improve this, to do more delayed cord clamping in OR or in the LND. My little bit interest is a fresh frozen plasma to prevent FFP. If you want to be peace of mind and just relax, then the systemic review and analysis will say no evidence of beneficial effect of FFP on IVH. But I didn't think so. It's as simple as this. Why they came to the conclusion? Because of 3 RCTs that I will show you in a while. And because of the famous statement, developmental homeostasis, or alternatively hemostatic immaturity, people keep away from touching coagulation profile and FFP. So what they mean by developmental hemostasis? They meant that babies, we know them prematurely, we know they have premature coagulation system, and it's okay with them. We should not touch it. I don't agree with this statement, because they have immaturity when they are in utero, not after delivery. So maybe we need to tune this statement. We have also 3 non-randomized controlled trial. 2 of them showed there is beneficial if you give FFP, and 1 showed there is no difference. I will go and look a little bit deeply on what they mean by hemostatic maturity. Andrew is the first one who published the reference range for coagulation profile. And if you look here, is only between 30 to 36 weeks. And it's really quite prolonged. If you have this PT and PTT in baby or 1-month-old boy, I don't think so, nobody will leave him alone. Another study showed the same thing, that the PT-PTT is very prolonged. But this study looks to smaller babies. So if we applied the Andrew criteria on babies less than 28 weeks, which were not included in the Andrew, then almost 90% of babies will have a coagulopathy. Christensen, strangely, when he published his reference intervals for coagulation, it came very narrow. We don't know why, although it's a large group, although it is a premature baby, but why they have very narrow or very low reading. And in their study, they didn't explain the reason. They accept only it is a normal values. A little bit, our data also goes with prolonged coagulation profile and confirmed that babies less than 28 weeks, their PT and PT is very prolonged. Let's move to one thing higher than PT-PTT. What's the problem of PT and PTT? One of them needs a large volume, 1 to 1.8 ml. It needs lab effort. It needs time. Now, in adult medicine, and in pediatrics, especially cardiac transplant and liver transplant, they use something more than PT and PTT. They use something called thromboelastography and thromboelastometry. These 2 technology, they measure the clotting formation and lysis in the tube, but in the similar way that in the body. What I mean by that, when we do BT and BTT, we're just measuring coagulation. We are not measuring the interaction between coagulation factors and between the other cells, like platelets. So in this technology, they try to do it and measure it in the body. The beauty of this technology, it is a point of care machine. It can be kept in the unit, and it takes 15 to 30 minutes, and you have the result. What's the downgrade of this? It is just start to emerge in the neonatology. It has been shown a good result in sepsis, a good result in asphyxia, where we can really pick the babies that are at risk of bleeding. They have different modalities and different machine. We hope one time we'll find it more in the neonatology. The other point I want to address, if you are not in favor of doing coagulation profile or not in favor of giving FAB, then we need to explain why babies less than 28 weeks are at risk of bleeding. 19 to 29 babies that deliver prematurely, they have a bleeding, either from lung or from GI or from the brain. So if you think hemostatic system is not in the equation, so why these babies, they have that much of a bleeding? Back to the meta-analysis that keep the people away from FFP and coagulation is very old meta-analysis, and there is no update because there is no randomized control after that. There is only 3 trials that look to the prophylactic FFP and prevention IVH. These 3 trials old, even because before the era of surfactant. The other thing, the gestational age that we are interested nowadays on, less than 28, is only 25% of their population. That means is not well representative. The other thing, the methodology is different. The most important, I think, in my opinion, in that study, they use infusion rapidly. They use 15 ml over 15 minutes, which is per se is a risk factor for IVH. Anyway, if I will look deeply on the first plot, and I use the grade update terminology, I will say the evidence is very uncertain about effect of FFP on IVH in infants less than 28 weeks. Just I would touch lightly on what we did in our unit and we published. Because IVH was very high in our unit and we did all what we think is correct and still it's high, then we moved to selective SDB. SDB is a FFB but exposed to detergent to kill all possible pathogens. So we start to screen the babies, and according to the Andrew criteria, if BTT and BT is prolonged, we give FFB 15 ml over 20 hours. And likely we could decrease the IVH, but this is a retrospective study and comparing between 2 historical periods. And also we were likely to decrease not only the IVH, we decrease also the severity of IVH. I will move to second object, which is head position. Head position, we remember in pediatric, in adult, when we have patient with increase in cranial pressure because of cerebral edema, we keep the head up and raise from the bed and midline. This observation was emerged and reached the ICU. And they found that the unit, they have less IVH than the others. They use this practice. They keep the headline, midline, and lift it between 10 to 30 degrees. But unfortunately, there is no evidence to support this idea. We tried to do a randomized trial, but we failed twice because of recruitment issues. The meta-analysis of all the trials published, 2 from Saudi Arabia and 1 from, I think, from States, they failed to show any evidence. But the meta-analysis, it was surprisingly, when you look to the IVH, there was no much association with head position. The head position cannot prevent IVH. But it showed us something that we were not aware when we do our analysis, which is the mortality. So head position, it may reduce the mortality. Maybe because reduce the infection, because maybe reduce the other thing, but it has been shown it might reduce the mortality. That's why after this meta-analysis, people start to do more head position in midline and raising them from 10 to 30 degrees. Let's move to something is hot debate between neonatologists, which is indomethacin ibuprofen prophylaxis. I remember when the TIB study published that time, we were discussing, we were resident, and the consultant at that time were saying, shall we stop prophylaxis? And I remember Dr. Majid said that time, no, I couldn't do that because maybe everybody will read the paper differently. And he was correct. Until now, every neonatologist will read the TIB study and interpret the TIB study differently. So what the meta-analysis showed, I'm going to concentrate on ibuprofen because indomethacin nowadays is not much available in our country. If you use different technique, different statistical model, you will get different result. For example, also when you use fixed effect meta-analysis, they conclude there is a marginally statistical significant reduction of the IVH. Now the other group, when they use network meta-analysis, if they use the statistical significant, they will end up with saying maybe it will reduce. But when they use, when they use the statistical, it will not reduce. When they use the grade approach, they end up saying probably reduce severe IVH slightly. The important of this meta-analysis is, I don't have the pointer, is the one, I want to show you, oh sorry. What the most important in meta-analysis is, there is no statistical significant reduction in severe IVH in babies less than 28 weeks, which is what we hope. So if you are hoping to reduce IVH in 28 weeks and use ibuprofen, you might not get it. We hope paracetamol will come and solve this problem. Now, my last part is prediction of severe IVH. As I presented now, is we don't have much evidence about head position, we don't have much evidence about FFB, and also in ibuprofen. But still, there is hope. So the people, what they try to do, try to select the most sick babies that they are at the highest risk of IVH. So they try to build a model. There is 7 models presented in the literature. The model shared one thing. All of them built based on logistic regression. And if it was built on logistic regression analysis, then automatically it will inherit the limitation of logistic regression. And one of the limitation is collinearity. And what I mean by this, they used 2 variables that very strongly related to each other. They use gestational age and birth weight. If they use two variables that very strong related, then maybe a good variable was kicked out from the regression model, and we should not kick it out. So there is one model here published from Vermont, Oxford, which is included the variable that you can see, but was not externally validated until Barbara Smith did post hoc analysis of her TB trial, hoping that this score will work better. So what they did, they applied their score in their cohort study, and they want to see if the babies at a group 4, that mean at highest risk of IVH, if we use indomethacin, their neurological outcome will be better. Unfortunately, the result showed there is no difference. So even if you use this score, you will not get what you hope. But they confirm one thing. If you use this score, you are going to harm less babies, and you are going to increase your number to treat. As you can see here, if you use only for the severe score, then you will treat only 11. Okay. The other score I want to show you is from South American. The same problem inherited like font. They have same variable that with collinearity. But the interpretation here is based on wagon nomogram. The other score I want to discuss with you today is the one from Turkish, since I don't have time. The beauty of Turkish is they include blood diathesis. Before I move to this slide, I want to alert you that all this score is retrospective. That means a lot of variable, we don't have it. So what can we do? The unit now start to do the bundle, IVH prevention bundle. And they include this 9 element in this bundle. They include thermoregulation, that you mean to keep the patient between 36.5 to 37.5. Minimal handling. They need first golden hour. You need to finish, and you finish all your procedure within 1 hour. Avoid lumbar puncture. Standardization of your care, respiratory as well as inotrope, and reduce the inotrope use. Noise and light, decrease it as much as you can, and in ICU characteristic. One of the good things, Dr. Saif is safe. He published a study that showed that if you put the plan for the ICU, and if the neonatologists do 24-hour on call, they were able to decrease the IVH significantly. Now, one of the things that was not mentioned clearly in most of the bundles is breastfeeding, and I think breast milk should be addressed very well. We know now there is a data emerging that even buccal and oral care with colostrum before feed prevent the neurodevelopmental delay, and even giving breast milk through the nose prevent the cerebral palsy in premature baby. So what is the key message I will deliver today? We need to have IVH prevention bundle that address the 9 points that I mentioned, and put the policy for URINET. You need to consider the timing and IVH score to prevent the severe score. You need to consider the midline head position, although there is no evidence, but at least there is no harm. You need also to use, you need to use IVH predictive model. If you are more active, you might do a study and validate that model. You need to study FFB, and I think we should need to consider that. Before I present my last slide, I want to show you this slide, which I like to show you. This is Dr. Majid. He is one of my great teacher that I learn a lot from him, and I would like to thank him. Next to him with Thob is Dr. Al-Kharfi, Allah yahfadha. I learn a lot from him too. Dr. Fawzal Khashlan, Dr. Tierney. The one with the blue skirt, Dr. Zakaria, unfortunately he couldn't attend the conference because he had a car accident 1 month ago, but he's doing great recovery. Thank you so much, and thank you for our great team.
Thank you for showing me so young. Thank you for this very comprehensive review, and hopefully that the bundle get spread in all units, and so that the IVH rate will become less.
Okay, thank you very much, Dr. Abdi. It's my pleasure to introduce our Prof. Sajjad Al-Rahman, consultant neonatologist at Al Habib in Al Qasim area at the moment. He's going to talk to us about neuroprotection bundle for the hypoxic ischemic encephalopathies. Please, Dr. Sajjad, the floor is yours.
Can you put the laptop on? Oh, it's okay. Thank you very much. Bismillahirrahmanirrahim. Assalamu alaikum. Thank you very much, Chairman, for giving me the opportunity to give an update about the neuroprotective bundles in hypoxic ischemic encephalopathy. So what we're going to review in another 20-25 minutes is what is already established in the management of hypoxic ischemic encephalopathy, and what are the recent advances which we are going to follow probably in the next few years, and what neuroprotective bundles we have proposed so far, and where is the future research on the subject. So what is already established? I think there is only one thing which is established, and that is the therapeutic hypothermia. And we have gone through a long period, so more than 25 years of research on therapeutic hypothermia, starting in mid-1990s from animal studies, followed by single human studies, followed by MRCTs, and then followed by the meta-analysis. This is the last meta-analysis on this subject, which was published in 2013 by Cochrane. And since then, there have been no other meta-analysis. The subject was closed because by that time, therapeutic hypothermia became a standard of care in all NICUs worldwide. Now, this is what the last meta-analysis said, that whether you cool the baby by selective head cooling or by whole body cooling, it reduces death and disability. And similarly is for the death alone, so mortality is reduced and morbidity is reduced. So the conclusion of all these studies and the last meta-analysis was that therapeutic hypothermia is beneficial in term and late preterm newborns who have got hypoxic ischemic encephalopathy. And then it went all throughout the world, and we adopted it as a standard thing. The established protocol which came out of all these studies is universally the same. We cool only term and near-term babies. Near-term is more than 35 weeks. And only those who have moderate to severe hypoxic ischemic encephalopathy. There is no consensus on mild encephalopathy. And we all follow the same criteria. Criteria A, criteria at birth, and criteria B, which is the bedside examination in the NICU, one from criteria A, one from criteria B, and both are essential. The criteria C, use of cerebral function monitor, is optional. And this is the protocol of cooling, which all have been following. Cool the baby to between 33 and 34 degrees centigrade, cool them for 72 hours from the time of starting the cooling, and then we rewarm them slowly over a period of 8 hours with the rate of rise of temperature not more than 0.5 degrees centigrade. And based on the physiology that all these 72 hours or 80 hours of period covers the primary and secondary energy failure, which is about the first 3 days of life. And we're going to go into a bit of detail later on. So with all this research and practice, we have learned 2 things about the hypoxic ischemic encephalopathy. So the first thing which became established is that it is possible to reduce disability after hypoxic ischemic encephalopathy, in fact both mortality and morbidity. But we also learned that though we are using therapeutic hypothermia, it is not a 100% prescription of a good outcome. It reduces the mortality and morbidity, and the efficacy is only 45 to 50% to a maximum. So it is not the whole answer, it is a partial answer. So then what next we are going to do? And that is what which has going on in the research for almost last 10 years. So therefore, we are now trying to find out some concurrent therapies which can help and support therapeutic hypothermia in increasing the number of survivals without any morbidity. And whether they can be used with therapeutic hypothermia or without therapeutic hypothermia is also a question. And then we are now assembling interventions which we call the neuroprotective bundles, and together all these may help in improving the mortality and morbidity because of hypoxic ischemic encephalopathy. So what are the recent findings? With all this research, we have also got a newer insight into the pathophysiology of hypoxic ischemic encephalopathy. The 2 important aspects which we know now is, the first thing is that the brain injury which happens after hypoxic ischemic insult, it is a dynamic process. It is a process which continues for a long period of time. We did not have this perception in the beginning. We thought it was only at birth, whatever neurons were damaged, and then later on nothing could be done. But now with the more insight into physiology, we know that this is a dynamic process, and which evolves and continues not only for hours and days, as we initially thought that probably 72 hours was enough. Now we know, no, this process continues not only for days, it continues for weeks and months and probably for years. So we have got a lot of time, and now we have been able to define each stage separately, and now we can say there are multiple interventions which we can do at various stages, and we're going to go through it very shortly. The other important thing which we have learned is that it is not only the death of neurons which is important, it is the death of non-neuronal cells which is equally important. And non-neuronal cells form the major mass of the brain. Neurons are a lesser part of the brain, and damage and dysfunction of the non-neuronal cells, whether these are astrocytes or glial cells or oligodendrocytes, contribute significantly towards the adverse outcome in babies who survive from hypoxic ischemic encephalopathy. So previously we thought that there was a primary phase and there was a secondary phase. The primary phase, which in the first 6 hours and which includes the period of transient recovery. And then we thought there was a secondary period of deterioration which we wanted to cover by therapeutic hypothermia, because we thought this secondary phase was due to release of chemical mediators produced during the cell damage in primary phase. That was correct in itself. But we also said that there is a tertiary phase, and this is a very long phase, and this is the phase of remodeling and recovery. This was from the studies of physiology, which was a very nice presentation. And here we can see that there is a first period from 1 to 6 hours with the latent period, that's the primary energy failure. Then there is a second period, 6 to 72 hours, and then there is a third period from 72 hours for a long period of time, spending up to months and years. And we can see the red line, it indicates the injurious mechanisms, which are very high in the very beginning, but as the time passes on, within 72 hours, they come to the lowest. And then there is a process of inflammation and repair which starts immediately after the insult, the green line, and as we go on, it increases and more repair is done. But the question is, does the repair go in the right way or does the repair go in the wrong way? If the repair goes in the right way, will survive without any disability. But if the repair process goes in the wrong way, the child will survive, but without any good neurological outcomes. So primary phase, what happens during primary phase, which is in the first 6 hours of life maximum, this is a phase in which there is primary cell death. That is the hallmark of this phase. The cells which are affected during hypoxia ischemia during this period, they die, and there are various mechanisms involved in this one. And this is what we have shown over here in the, between the red and green line, you can see the mechanisms. Then the secondary phase, which lasts between 6 to 72 hours. This is a phase which is different from the first phase. Here the cell death is what we call the programmed cell death. So the cells die in a very specific way. And the two specific ways are, one is the necrotic cell death, and the second one is the apoptotic cell death. In the upper part, I have shown that how these mitochondrial collapse, cell swelling, seizures, and inflammation lead to the programmed cell death. And then below is the mechanism of these two cell death modalities. And this is shown over here in the second phase. And you can see our hypothermia in the bottom of the slide is shown. Hypothermia covers only up to 72 hours. So it is covering only between the time of the insult and the 72 hours from the time of starting of the hypothermia therapy. So what after that, we yet do not have any answer to that. There are a lot of trials going on, and I'm just going to give you a bit of highlight about that. What else we can do after this period? Now the third period, which you call the tertiary phase, is the phase of remodeling and recovery. And during this period, there is impaired connectivity. At the time of birth, the newborn brain has as many number of neurons as the adult brain. So there are no neurons formed. And the problem with the neurons is that they are highly differentiated cells. Once the neurons die, they are not replaced by another neuron. They are replaced by connective tissue, which in the brain we call the glial tissue. So this is one important issue. The second thing is, after birth, what happens in the newborn brain is most of it is the development of myelination and the connectivity, and that is what leads to progressive development of the brain and the neurological function. Well, a newborn baby cannot sit, he cannot stand, but at 6 months he starts sitting, at 1 year he starts standing, and then starts walking. This is all a progression of myelination, and myelination always progresses cephalocaudally from head to toe. That's why the babies first start holding head, then they start sitting, then they start standing, then they start walking. If a child does not hold his head, he will never stand and he will never walk. These are very simple principles of neurodevelopmental follow-up. So what happens during this period is that all those non-neuronal cells which are involved in the development of the brain, which are involved in the development of the functions, they do not get up to that level because they have been damaged by hypoxia and ischemia. This is the most recent diagram published 3 months ago in August 2022, and I like it. It's a very important one. And it gives everything very nicely. It gives the same 3 phases: primary energy failure with latent phase. I'm talking about the middle of the slide. Then there is a secondary energy failure, and then there is a tertiary failure. The upper part gives us the mechanisms which are involved in the damage of neuronal tissue, both neurons as well as non-neuronal ones, and how it works during each phase. And the lower part gives us the therapies which we can potentially start in each phase. And you know the blue line, this is therapeutic hypothermia. This is the only established thing we have got so far. The second thing is control of seizures, which is very important. If seizures are not controlled, they lead to secondary neuronal damage. And this can happen both during secondary as well as the tertiary phase. Then now we have developed neuroprotective bundles, and there are 2 types of neuroprotective bundles. The first one, which I have shown you, which works in this first 72 hours, is what we call the acute injury prevention bundle. And I'm just going to tell you what actually it includes. And the second bundle which includes is called the neuroplasticity bundle. It's in the in the tertiary phase, it's the other end of the same bundle line, the red line. So we have got two types of bundles which can possibly help us in protecting the neurons. And then the people are adding more neuropharmacologic agents to, sorry. And some people are trying to use the melatonin in the first primary and secondary phase, erythropoietin in various doses, and of course the new thing coming is the stem cell therapy. So the neuroprotective bundles, which we have so far tried to put it together and see how they work. One is the acute brain injury prevention bundle, which, as I have said, is in the primary and secondary phase. And the second is the neuroplasticity bundle, which is in the tertiary phase. So acute brain injury prevention bundle, it includes early identification and referral of the patient who has suffered from hypoxic ischemic encephalopathy. Most of the problems happens when there is delayed referral and we cannot cool the patient. So that's one important thing. Second is preventing fluctuations in physiologic parameters. When the baby is entered, we should look for all these things, maintain normal carbon dioxide level, maintain normal glucose, blood pressure and temperature levels. Minimal handling is very important, pain management is very important. The diagnosis and seizure and control and management of seizure is very important. Seizures, as I said, can lead to secondary neuronal damage because of the episodes of hypoxia which happen with it. Then early nutrition, fluid and electrolyte balance are very important. And within this period, primary and secondary, first 72 hours, we have got some protective interventions. The well-known, as I said, is therapeutic hypothermia, but the others which are being worked on is erythropoietin and melatonin. And there are a number of other candidate pharmacologic agents which can potentially help in protecting the neurons or the neuronal tissue in this one. Could be magnesium sulfate, xenon, allopurinol, and there is a long list of these agents, and the agents are increasing in number every day. But there is no yet proven study which can say that they are definitely helping. The neuroplasticity bundle, which we start off with these first 72 hours in the tertiary phase. These bundles target potential brain injury and growth well beyond the first few days of birth and after discharge at home. So the management is actually a very long-term management. We need to follow them and make sure that all these things happen. And the elements which have been put into the neuroplasticity bundle include the empowering families through family integrated care. So the parents need to understand that what exactly has gone wrong with their child and what exactly they should be doing, and they should be prepared for and willing to do that. Then optimizing nutrition, developmental care, skin to... Sorry, something gone wrong? Sorry. So skin-to-skin care and the massage therapy, which obviously is the function of the physiotherapist. Positive stimulation by various kinds of sounds is being used, and encouraging positive social interaction, which can lead to better neurodevelopmental outcomes. Though we have put all these things in one bundle, and there are other potential pharmacologic agents like long-term use of erythropoietin, not only in the first 3 days, but for a few weeks and probably for a few months in a higher dose as a neuroprotective agent. And the last one, which is coming up with a lot of publications, but still very uncontrolled, is the stem cell therapy. Stem cell therapy is basically a replacement therapy. It brings new cells into the neurons, which potentially have the ability to become converted into neurons or other neurological cells and help replace those neurons which might have died. But again, there is no evidence and no meta-analysis to show that these are really effective. So this just 1 minute.
5 minutes, sir.
1 minute, just 3-4 slides left. So neuroplasticity bundle. So there is limited evidence that neuroplasticity interventions can improve long-term cognitive and motor outcomes. So we need a lot of trials and research into this. It's open for work. So again, I'm showing the same slide. It's one of the most important slides, and I like it very much because it bundles up every single thing which I have set into one very good diagram. It's easy to understand for those who want to do the clinical practice as well as those who want to do research in this field. So the future research, that's the last thing I wanted to mention. So we need to understand the safety, efficacy, and long-term outcomes of neuroprotective therapies, whether they are used with therapeutic hypothermia or without therapeutic hypothermia. So we need to understand what is their role. And this is what is going on. In next few years, we might be able to have more evidence and more meta-analysis and may come to some kind of combined therapies. Then the bundles which we are proposing for the protection of neurons and neuronal tissues, what is the outcome of that? Do they really help? Do they really reduce the neurodisability? We yet don't know. So a lot of trials are needed over there as well. And stem cell therapy, and what is the outcome of stem cell therapy? This is a practice which is going uncontrolled in many parts of the world, including China and India and probably Far East. And a lot of people are getting the ideas from the internet and they're going. But nobody knows what actually is being done. There is no controlled trial and there is no regulation of this stem cell therapy. So it's a random thing going on, but hopefully we'll one day have some proper trials and find the outcomes. So the future is we have to put the things together. A lot of therapies together, maybe therapeutic hypothermia, some pharmacologic agents, and some non-pharmacologic interventions, all put together to reduce the mortality and morbidity from hypoxic ischemic encephalopathy. That's what I call the cocktail therapy. Thank you very much. Appreciate it.
Thank you very much for your time. Yeah, next.
Our next speaker is Dr. Saif. He's going to tackle another important problem in the NICU, which is chronic lung disease. And Dr. Saif is a consultant neonatologist and a chairman of neonatal intensive care unit. He has contributed a lot to the teaching and dissemination of neonatal care in the kingdom over the years. So I consider him one of the pioneers and senior neonatologists in the kingdom. Today he's going to talk about how we can prevent bronchopulmonary dysplasia. Dr. Saif.
Assalamu alaikum wa rahmatullah. Good afternoon, ladies and gentlemen. Can I see a slide, please? Thank you. I'd like to thank the scientific committee for choosing me to be one of the speakers actually in this annual Saudi Neonatal Society conference. It's my pleasure to be here with you. I was asked to talk to you about prevention of bronchopulmonary dysplasia. I wish I was here yesterday. I was busy trying to finalize the plan for Women's Hospital, which is going to open maybe next month. It's going to be a big unit, 96-bed unit, fourth tower of Children's Hospital. So today I will talk about mainly about prevention. I will have some introduction. And we'll start with the sad story. In 1963, the President of the United States had a second son. Was delivered by cesarean section at 35 weeks, and unfortunately he died after 39 hours of suffering from severe HMD. This actually severe tragedy it's provides spotlight on how big deficit in healthcare system at that time. This helped in spur the advancement of medical technology and researches and development of neonatal medicine. So a few years later, in 1967, after invention, after babies become on mechanical ventilation and survived, they start to develop bronchopulmonary dysplasia. And the first one described this disease is this gentleman called Northway. Actually, he's not a neonatologist. I was surprised that he's a radiologist. And he was just describing the disease for those babies survived after severe HMD. Those babies actually delivered at the end of saccular stage and the alveolar stage. They born usually after 30 weeks gestation, but with severe HMD. And since that day in 1967 till today, more than 55 years, we're still talking about BBD. Why? Because it's very common neonatal problem for premature infants, 30 to 60% of extreme low birth weight infants. It's very difficult to prevent. It actually have a risk of mortality and high risk of morbidities, including neurodevelopmental outcome. It's actually have a length of stay in the hospital, increased separation of the parents from the babies, and also increase the cost. So his description was only describing the lungs, that it's hyperinflated, atelectatic, etc. And this is all before and pre the era of antenatal steroid and before the era of surfactant. Then we did not finish. After we start surfactant, we start to give antenatal steroid. We have some new BBD, which babies born at the middle of canalicular stage to the middle sacral stage, between less than 28 weeks, and they have homogeneous lung opacity with simplification of the alveolar with less septation. And the first one described this disease is Alan Job in 1999. And affect babies less than 28 weeks with the era of surfactant and antenatal steroid. This BBD have many definitions, as Dr. New yesterday was saying. If you have a disease with too many definitions, that means it's not a good definition. And the most common definition used in the literature is NIH definition in 2001, when they say if the baby does not need oxygen more than 28 days, that doesn't have BBD. However, if he needs oxygen for more than or equal 28 days and at 36 weeks post-menstrual age in room air, he have mild BBD. If he need oxygen at 36 weeks post-menstrual age, less than 30%, moderate BBD. And then if he need mechanical ventilation or invasive ventilation or non-invasive or more than 30% oxygen at 36 weeks post-menstrual age, means he has a moderate, severe BBD. Then the last definition, which just published by Jennison et al., and he make it very simple, straightforward, babies less than 32 weeks, any respiratory support at 36 weeks, or discharge, irrespective to the prior duration of current level of oxygen. If they are nasal cannula, less than 2 liters, they have grade 1 BBD. If they need nasal cannula more than 2 liters or non-invasive ventilation, grade 2. If they are in invasive ventilation, that means they have grade 3 BBD. Bronchopulmonary dysplasia, it's become more when the baby is smaller. If you look at the black dots in the bars, so more than 50% of babies born at 22 weeks, 23 weeks, they will die before reach 36 weeks post-menstrual age. If you look at the green part of the bars, that means the baby have no BBD. 23, 24 weeker and 22 weeker have, most of them they have BBD. However, babies 29 week, maybe 20% to 30% they will have BBD. So how to prevent the disease? We need to start before actually baby delivered. Antenatal, there is antenatal factors. We cannot do nothing for this one. There is genetics makeup, epigenetics, or fetal programming. Babies IUGR, mother have problem with nutrition, placental insufficiency, or maternal illnesses, or too many antenatal steroids can affect the lung growth and alveolization. So IUGR in preterm infants is independently associated with risk of BBD due to decrease of lung growth. Protein deprivation during pregnancy impair alveolization in animal models. High fat diet during pregnancy is also associated with wheezing and asthma in the offspring. In utero smoking, smoke exposure, modalities can modify, methylation and specific gene to increase the risk of BBD. So postnatal factors, pre-disease, baby immature lung, then we give oxygen, ventilation, oxidative injury, volutrauma, apnea, hypoxic event, poor nutrition for those babies. It may increase the risk of BBD, so we need to tackle these ones. Or the lung disease itself, because of too many steroids, may be alter the alveolarization and those infants. So today I will talk to you about established approach in prevention BBD. I will not talk about pending trials. So I will start with you when the baby born prematurely. So first of all, when the baby in labor and delivery, covered with the plastic bag, we start CPAP immediately. It's shown in many meta-analyses, this one published in 2013, that avoiding mechanical ventilation will decrease the composite outcome death, or BBD. Another recent trial actually found it's mostly affecting babies less than 28 weeks if you avoid mechanical ventilation. However, does not affect babies more than 28 weeks. However, the total overall, it will decrease the risk of BBD and death if you avoid mechanical ventilation for those tiny babies. Then in 2010, 2015, there was a popular talk about or sustained inflation, and it's most commonly in Europe because there is many animal trials showed using that means it's a pressure of 15 to 20 for 10 to 15 seconds, it may improve the lung inflation and decrease the risk of BBD and decrease the risk of intubation. However, this maneuver was questioned because there is many studies, it's not consistent, many studies, it doesn't have the same protocol. So in JAMA, 2019, there is a randomized control trial trying to test this hypothesis. So they tested babies on CPAP to give him 2 puffs of 15 seconds of positive inspiratory pressure, about less than 20 pressure for two puffs, two sigh. And what they found actually it was randomized control trial, more than 9 countries. Their target was 600 babies. However, because of increased death during the study, within the first 22 days, they terminated the trial after 426 infants, and they found 16 babies died in the sustained inflation maneuver compared to use standard resuscitation. So it's not recommended to use PSI anymore. Then do we use CPAP or use nasal intermittent positive pressure ventilation? Doesn't make a difference in regard to chronic lung disease, so it's the same. However, over the last many years now, everybody trying to avoid mechanical ventilation, using non-invasive ventilation. There is almost 3 very big retrospective cohort trials, and this is one of those, trying to report the change in pattern using respiratory support for preterm infants. So over 7 years period and 56,000 babies in England and Wales, they found the non-invasive ventilation primary support increased both CPAP and high-flow nasal cannula. However, the high-flow nasal cannula was increased dramatically, almost 7-fold. 14% it was in the past, and then over the last 7 years was 68%. The survival rate increased. However, there is increase in mortality and morbidity, including BBD. And it's astonishing when you see the result in this trial. They found the high flow is less mortality, but if you looked at the BBD, bronchopulmonary dysplasia, in the high flow 47% versus CPAP group 17% only, and goes on with the death and BBD, late onset sepsis, neck needs surgery, and PD, all of them, they are very high in high flow compared to CPAP. So we try to avoid using high flow as a primary support for those babies. So another trial in USA, they have 40,000 babies, and they found the use of mechanical ventilation decreased by 15 to 20%, but the BBD rate did not change. Another one in Spain, 18,000 babies, they found decrease of using mechanical ventilation, but again the BBD rate did not change. So why? Is less really more? Is less using invasive ventilation, it's more beneficial for babies? That does not show this in the literature. So maybe non-invasive support modality carry potential risks such as atelectotrauma, increased intermittent hypoxia or hypoxemia, longer exposure of supplemental oxygen or support. This may be negate or contradict the benefit of granted by reduction of mechanical ventilation. Now the babies on CPAP going to NICU, we are giving oxygen. Do we resuscitate this baby using 30% oxygen or 60% oxygen? This is the meta-analysis of 8 randomized control trial. They do not show a difference using 30 versus 60% oxygen. So we use less oxygen to avoid oxidant injury for those babies. Surfactant, then we decided to give surfactant because the baby need high oxygen and severely retracting. So is it better to intubate, give prophylactic surfactant, or manage them on CPAP? Actually, there was many big trials like Cohen, support trial, and others concluded that better to start with CPAP support in the delivery room if possible, then intubate and administer surfactant only if the infant with severe RDS. So maybe surfactant alone does not prevent or improve the BBD rate. Maybe if we add steroid to the surfactant, it will help. Actually, this recent meta-analysis showed inconsistent results in this regard. Only et al., which published in 2016, showed a significant decrease in the rate of BBD, but still is not clear in the literature. So what we are waiting for now, we are waiting for a PLUS trial, preventing lung disease using surfactant and steroid. This is a phase 3 and international multi-center prospective blinded randomized trial to be conducted in NICU Australia, New Zealand, Canada, and Singapore. We'll see the result, what we'll come up with. So prophylactic surfactant with Ensure, maybe intubating the baby, giving surfactant, it affects the lung damage even with few puffs. Maybe if we just give the surfactant and remove the tube, or give only CPAP. So several studies did not find benefit of prophylactic surfactant with Ensure over CPAP. And this is what showed in the meta-analysis. So the American Academy of Pediatrics European guidelines on surfactant administration advised stabilization of preterm infant on CPAP and if necessary the administration of surfactant as early as rescue therapy preferred within 2 to 3 hours after birth. So maybe when we give the surfactant, we are not inflating and recruiting the lungs. So there is another study published last year called Ensure versus Ensure. Ensure means intubate, recruit the lung by using high frequency, give surfactant, extubate. This is trial unblinded trial compared with surfactant administration after alveoli recruitment using high frequency or Ensure for 30 minutes. It's more than 500 babies between 24 to 28 weeks. They do not show a difference in incidence of moderate to severe BBD, but there is a reduction in mechanical ventilation used in the first 72 hours in Ensure group. So maybe using mechanical ventilation will affect the lung. Maybe if you use it, use minimal invasive surfactant therapy without intubating the baby, it will help those babies by using CPAP and giving the surfactant through LISA or Take Care, mist, or Calmist with combination of LISA and mist. The meta-analysis showed there is a superiority and there is a benefit of using LISA versus mechanical ventilation and decrease the risk of bronchopulmonary dysplasia. But again, there is another randomized control trial published in 2001 in JAMA by Dargaville, the Optimist trial, collaborative paired trial investigating minimally invasive surfactant therapy. It's a randomized control trial between 25 and 28 weeks gestation. They recruit 485 babies in 33 centers in Europe and giving surfactant through LISA protocol versus CPAP. So they found the BBD rate decreases, PDA medically treatment decrease risk of intubation within 72 hours, and decrease risk of intubation during NICU stay. So now we give the surfactant, the baby extubated, but you need caffeine to make him breathe and avoid re-intubation again. We cannot talk about caffeine without talking about CAP trial published by Barbara Schmidt in 2006. She found caffeine significantly reduced the frequency of BBD, 36% versus 46%, earlier successful extubation, earlier discontinuation of BBD, positive pressure ventilation, and earlier wean to room air. So do we give it early or late? Davis in 2010 have a post hoc analysis of CAB trial. So follow-up. What he found a great reduction in the duration of respiratory support among infants who received caffeine within the first 3 days. Very interesting finding. They found less death and major disability with early caffeine, less cerebral palsy, less BBD, and less PDA ligation. However, in a big number of babies in United States, multi-center observation cohort study in 366 in ICU in USA, more than 10,000 babies did not show a difference between mortality, BBD, and other comorbidity, giving caffeine in the first day or give it later. So, however, they found that caffeine even is not associated with decreased risk of CPAP failure in the first week of life for very low birth weight infant. More astonishing result by Amaro in 2018, published in Journal of Pediatrics. It's early versus late caffeine, double-blinded RCT trial found no difference in successful extubation between early versus late caffeine, and this trial was terminated due to unexpected trend of mortality in early caffeine. So we have to be careful. We are using now caffeine all the time, even baby ventilated in high frequency, and we're not planning to extubate for another week or two, still the baby taking caffeine. However, the right answer, hopefully, it will come from the RCT was conducted and completed by July 2022, and we are waiting for the result to see if giving caffeine in the first 2 hours is beneficial or not, or safe. Oxygen saturation, again, we have
5 minutes more. 5 minutes remaining.
Okay. Association between high saturation versus low saturation, or using 91 to 95 versus 85 to 89. It's a new PROM trial, more than 5,000 baby, more than 5 trials, did not show a difference in the outcome. So, however, Askin et al. Recommended using saturation of 90 to 95 in those babies. Maybe it's safe, and European census recommendation in 90 to 94% will be safe for those babies and improve the outcome. Maybe using high frequency will improve the outcome. However, in the literature there is a meta-analysis in 2005 with a different outcome, and so it was better in the early 90s, but in the late 90s and early 2000 did not show a difference in the incidence of BBD or death. So their conclusions was optimizing CMV strategy appeared to be as effective as using high frequency in improving pulmonary outcome in preterm infants. Another meta-analysis actually did not, or maybe showed a little bit of small inconsistent reduction in BBD using high frequency as first initiation trial. So maybe using conventional ventilation with volume target will improve the outcome, and this is what showed in more than one meta-analysis by decreasing BBD rate in those infants. So maybe using volume target ventilation will be the way to go on those tiny infants. PDA is maybe a contributing factor for BBD, so if you close it, it will make a difference. This was tested by Kleiman in 2019, and his study called PDA Tolerate, to leave it alone or respond and treat early trial. Actually did not show any improvement in BBD rate in babies less than 26 weeks. Or more than 26 weeks. However, for baby more than 26 weeks, they found higher rate of death due to late onset sepsis in the treatment group for PDA. Then Kleiman again, he followed up with those babies and tried to find the relationship between PDA and exposure to mechanical ventilation. He found if the babies ventilated more than 10 days, the risk of grade 2 to grade 3 of BBD will be higher, and also the exposure of moderate to severe BBD, as it's longer, it will be higher for BBD rate in those infants. Steroid antinatally does not help in decreasing BBD rate. However, if you give it less than 7 days, it will decrease the rate of BBD but increase the risk of cerebral palsy. And if you give it more than 7 days, it will decrease the rate of BBD and does not change or does not affect cerebral palsy, so unless you give it a high dose or longer period of time. Then maybe using hydrocortisone will have less side effects than dexamethasone. Multicenter trial, double-blinded, randomized control trial, found no actually different in the outcome by using hydrocortisone versus placebo. So maybe if we give the steroid by inhalation, which called the study published in 2018 called Neurosis, Neonatal European Study of Inhaled Steroid, it may be improve the outcome. It does decrease the BBD rate, but increase the mortality rate in the intervention group. So it's not recommended to use inhaled steroid for those babies. American Academy of Pediatrics just published in June 2020 a postnatal steroid statement and summarize it. To use routine use of steroids is not recommended. If you want to use it, you need to speak to the family and take the consent and document in the chart. Low dose of dexamethasone less than 2 milligram and less than 14 days, maybe it's okay, recommended. However, high dose of dexamethasone more than 2 milligram is not recommended. Less than or equal 7 days of age using hydrocortisone to prevent BBD or death. For babies less than 1 kilogram, mainly if exposed to corium nuts will be beneficial. Don't use steroid and indomethacin. Vitamin A is being used and shows some benefit, but is a problem with availability, problem with giving babies 3 injections intramuscularly 3 times a week for 4 weeks. Nutrition, we cannot speak about BBD without talking about breast milk. Breast milk decreases the BBD rate, and infection increased the BBD rate. Nosocomial infection decreased from 24% to 15%. It decreases the rate of BBD by 8%. Using of antibiotics more than 4 to 7 days is associated with increased risk of BBD. Additional day of antibiotics in the first 2 weeks of age significantly increase the risk of severe BBD. So we conclude strategy that theoretically effective to prevent BBD have failed to translate into clinical setting. BBD multifactorial. It's highly unlikely that single therapeutic intervention will have significant effect on outcome. And I like this statement from Greenoff. What did she say in her commentary on hydrocortisone study? We should stop looking at the silver bullet and move toward assessing the combination of intervention. And lastly, Eric Jennison, I like his statement, proposing a new paradigm in neonatal respiratory care that target improvement of postnatal lung growth to achieve substantial gain in BBD prevention. By this, I would like to thank you all, and sorry for the wait.
Thank you very much, Dr. Saif, for this comprehensive review with a lot of questions to come.
It's my pleasure to introduce Dr. Muhammad Al-Hindi. He is consultant neonatologist at King Abdulaziz Medical City in Jeddah. He is a clinical assistant professor of pediatrics, joint appointment in College of Medicine, King Saud University for Health Science. And this is certified trainer in postgraduate medical education, Department of Pediatrics in the ICU section, King Abdulaziz Medical City in Jeddah. He is going to talk to us about the deferred umbilical cord clamping as quality initiative. Welcome, Dr. Hindi.
Okay, thank you very much. I would like to thank the scientific committee for giving me this opportunity to talk about the topic. بعدما ذهب العظام بالمسائل الكبار وجلوه جالي دكتور سعد وقال لي هذا حبل علمني متى نربطه. For technical reason I don't see the title appearing here. However, the cord clamping at the beginning, at the time of human beings as we know, there was pregnancy and there was birth and there was cord clamping. We don't have a report when used to before the date of the first literature when the cord was usually clamped. If you go to our ancestor or you are going to our grandmothers, they will even actually say, why you are in a hurry? You know, it's a baby, he has the placenta and the cord to connect to it, and we'll clamp it anytime. So by natural, actually we should, in our literature, we should say the intervention is early cord clamping. Is it beneficial or not? And the control or the standard approach is the deferred or the delayed cord clamping, or the usual or cord clamping. So when I looked into literature back, even as early 50s, the early clamping started to trickle and appear after they started doing some physiologic studies on mammals. And they actually calculated the amount of blood in each pulse in the cord, eventually saying by 1 minute you will receive around 80 to 100 ml of blood, and by 3 minutes and 5 minutes you are already late, khalas. So they define it by 1 minute and late clamping at 1 minute. Then there was a gap where there was nothing, there was no trials, there was no specific recommendations, and ultimately the cord clamping became shorter and shorter. Why? Because more advanced care, now we are saving more preterm babies, and the obstetrician want to go to, يلا give the baby, أعطيه للنيوناتولوجيست خلينا نخلص, تمام? So eventually ended up by immediate cord clamping, and usually done within 15 to 20 seconds. And even I remember the days, so بسرعة, okay? Nowadays, a great author said, after coming a full circle, the ancient practice of deferred or delayed cord clamping is popular again. Right. Some people will say, what do you want to say, delayed or deferred? I would refer, you will see in the literature, this word terminology is being used interchangeably. I would prefer deferred. However, now it's becoming popular again, so the last 2 decades, many trials were done. And not only that, many systematic reviews were done. And not only that, there is a systematic review even done. So I was swamped with literature, what to do, what to say, However, the professional organization now recommends the deferred cord clamping in term and preterm infants. In summary, for example, the WHO, since 2012, they recommended more than at least 1 minute of deferred cord clamping after birth in term and preterm infants who do not require PPV. The NRP guidelines by the American Academy of Pediatrics also, they suggest 30 to 60 seconds. The Royal College of Obstetrics and Gynecology also, they recommend for at least 2 minutes. And for the American Society for Nursing and Midwifery, also they recommend 2 to 5 minutes, so they're more liberal. Now these recommendations actually were based on many reviews done and many trials, and they are all both, we are talking about both term and preterm infants. And of course, when I say the deferred cord clamping, you have concerns. Concerns start to appear. So one of the concerns that you might delay the resuscitation effort if you need, especially in preterm infants. Now the trials actually are talking about intervening while the baby is still on the mother's lap or below the mother's pelvis. And it's been shown at many occasions, on many trials, that being the placenta still attached and the baby still attached to the cord, you'll actually get a benefit from the blood flow coming from the placenta. How about the potential for excessive placental transfusion? It's been established in many trials that it only shows a mild increase in neonatal jaundice. That if you have a reasonable program, you might notice a little bit of increase in phototherapy. However, no kernicterus were reported. How about deferred cord clamping and IVH? Actually, it's not in deferred cord clamping, it's in the umbilical cord milking. So another practice, obstetrician previously used to do, is that if they think the baby needs immediate resuscitation, they will just bring the baby out, start squeezing the cord, and do what we call the umbilical cord milking. And so many trials done on that, and in 2019, a study that was halted early with 447 infants enrolled, and it was because the extreme preterm infants in the umbilical cord milking was more often to develop IVH compared to those similar with just deferred cord clamping. So hence the recommendation below 28 week, do not do, be careful or don't do the umbilical cord milking. However, anything above 28 week, there is no evidence to support or refute doing umbilical cord milking. But here, still the standard practice is to do umbilical cord, deferred cord clamping. So what are the obstacles? Now, it is simple and inexpensive practice. And most of the units, when you go to them, they will say, okay, no problem, we can implement the deferred cord clamping in term infants who are vigorous, no problem, we can do that easily. They'll just issue a memo and they will do it. However, the challenge comes later on in the preterm infants or infant who require gestation or in the multiple gestation. There should be a setup for and a very clear pathway of how to implement such deferred cord clamping. So whenever you do a quality initiative process, you'll have a persistence of custom. هذا ما وجدنا عليه آباءنا. So you'll find that. And also lack of awareness and the confidence level of how the baby, how stable is the baby. And of course, you might see conflicting over guidelines. Even with all the society's recommendation, a study in California showed that only 42% of preterm infants less than 32 weeks did not receive the deferred cord clamping. In Canada, 40% of preterm infants, 53% of extreme preterm infants in 2018 did not receive cord clamp. Remember, these are 4 or 5 years ago studies. Nowadays, most probably these practices actually might increase. How about deferred cord clamping in Saudi Arabia? I tried to search any published literature. I found a very nice article about the current delayed cord clamping practices and attitude among obstetrician midwives toward delayed cord clamping in Saudi Arabia. So the objective of the study was to investigate the current practices of healthcare professionals and the timing of the umbilical cord clamping in Saudi Arabia, and it was a cross-sectional survey. It included 5 tertiary centers in Riyadh, and it was done from May to October 2016. And it included obstetrician midwives and completed via questionnaires. And their outcome was the current umbilical cord clamp practices and attitude of obstetrician midwives towards the deferred cord clamping. So it included 157 respondents, and most of them, and of course from our sister hospitals in Riyadh. If you are in Riyadh, you know the abbreviations: King Fahd Medical City, King Faisal Specialist Hospital, King Abdulaziz Medical City, and King Salman Military Hospital or Medical Complex, and of course National Guard. And of course, mostly were female, and mostly were equally between obstetrician and midwives, and the higher education level, and of course they had the excellent degrees, and they had a very reasonable experience while working as in the obstetric field. So the results at that time, if the question asked, do you have an existing guideline of umbilical cord care, just umbilical cord clamping time? And you will notice that 40% of them, or more than 50% of them said no. And if you have a setup time, so do you have, if you have a guideline, you have a setup time, like 1 minute, 30 seconds, 1 minute, etc. And more than 50, almost 60% of them said no. And you will notice that practices of doing the umbilical cord clamp varied between just doing it for no reason, according to unit protocol, or to prevent polycythemia, hyperbilirubinemia, or minority, they say, we're not worried, I will not clamp it until the baby is, I'm not worried at all. Some actually had some interesting thoughts, like wait until the pulsation have ceased to optimize blood supply, and etc. Now, if you ask these personnel when you are going to close or you clamp the cord early, majority agreed that if the baby had a low Apgar score, meaning that the baby is requiring active resuscitation. And this is actually not different from the literature. So, and also if there's a short umbilical cord, and if they are worried about knuckle cord, and worried about a lot of vaginal, maternal concern or vaginal. However, 33% they answered, I always do umbilical cord clamping immediately. So that was the practice at that time. So if the question asked, when is the occasion for doing later umbilical cord without timing, okay? The answer was 45% they don't do, so the late clamping. Also, some answers you will see that while the umbilical cord is still pulsatile, and then once this pulse ceases, then they will start clamping. And if the placenta is still attached, and if the mother is breastfeed, they can delay the cord clamp, and etc. So these are some cognitive questions if asked for these healthcare providers. So, do you have setup time? The reasons for umbilical cord in preterm infants. So setup time, they didn't know anything about setup time. At that time, 65%. And majority also, the reasons for delaying not doing the delayed cord clamping in preterm infants, the majority said they're worried about the condition of the child. And what about elective C-section? Also, they said we don't have time, they will do it as soon as possible, most of the at the time of C-section. And if there is sorry, because it's clear here. Oh yes, so the elective C-section and emergency C-section. So this, whether you are C-section, whether vaginal delivery, it didn't matter. So they will, majority will not do it. So going to the cognitive part, if they ask the question, delayed cord clamping is good for preterm infant, not requiring PPV, majority, they said yes, agree. So they are in depth their knowledge, they know it's beneficial. It's good for baby not requiring PPV, the majority said yes, or correct answer. And even for babies who's requiring PPV, majority also, they answered well. The least favorable answer was if the delayed cord clamping is not applicable for babies delivered by C-section. So they answered wrongly most in this case. Okay, so this is the situation in Saudi Arabia. What happens then? This is, and this will be my cumulative slide of, because I will not take a long time here, cumulative slide of guidelines on deferred cord clamping and cord milking, which was a systematic review of major recommendations or summary of recommendation on deferred cord clamping and cord milking. And if you see this one, this sign, it indicates the deferred cord clamp, and this one, this is the deferred cord clamp, and this is the umbilical cord milking. And they found almost 44 statements from variety of, from the WHO, ACOG, Royal College, and 69 recommendation on the delayed cord clamping. And for the preterm infants, they found almost 36% recommended 30 to 60 seconds, up to duration 30 to 180 seconds. For term infants, also the same, They recommended 30 to 60 seconds when cord pulsation ceases after delivery. So the usual recommendation is 30 to 60 seconds. However, some recommends also until the cease of the pulsation, cord pulsation. If you combine both, either to preterm or term, they might recommend more than or less than 30 seconds if the cord pulsation ceases. So the common contraindication, so when is not to do cord clamping, of course, if the need for early support, heart rate less than 60 per minute, fetal anomalies, and for maternal reasons, of course, if she's unstable, bleeding, or she has placental problem. For the umbilical cord milking, almost 23 recommendations, and 65% of them suggest umbilical cord milking when the deferred cord clamping is not feasible, is only half. So when you suggest, either it is because the deferred cord clamping is not feasible, or if the early neonatal support is needed, then 47% they recommended using the umbilical cord milking. However, be warned, less than 28 weeker is still under study, so do not do it. I would like to, all these sessions before, they were about the quality, so quality initiative. So you are in a unit, and you want to do a quality improvement project to improve your delayed cord clamping. And as our great author before, you don't try not to do it alone. Now, even the literature now, current literature we found is the delayed cord clamping was considered as a bundle of neuroprotection, as a bundle to improve neonatal care. So it's not being treated alone. I'll just do cord clamp والبقية ما حسب لها شيء. لا. It is part of the bundle, so it includes preventing hypothermia, early surfactant, and delayed cord clamp, etc., etc. So
5 minutes more.
Sorry? Okay, so basically you establish your literature review, convince your administration that it is needed, check your local rates and compare them to benchmark locally and internationally how many deferred cord clamping you're doing. And involve the stakeholders, patients and their parents, and of course if you're an obstetrician, the mothers and the husband, and of course organizational head of departments, and if you have any neonatal networks, and assign team leaders. Most of the quality improvement projects, I found that they are successful if you assign the leaders from nursing or from midwives. So assign appropriate motivated team leaders, and check the measures that you need to check for it. Initial data collection should be looked at practices prior to the deferred cord clamping, and to identify the barriers, and do the series of PDCA cycle to evaluate the implementation guidelines in the unit. And suggest various strategies. Do a brainstorm session and suggest various strategies. For example, observation of practice at another tertiary center with higher rate of deferred cord clamping. There are trolleys now. I'll show you the video for that. Life Start, it's called Life Start trolleys, where there is a mannequin and the multidisciplinary team approach, where the neonatologist, respiratory therapist, the midwives or the neonatal nurse come and resuscitate a preterm baby in this trolley while the mannequin of the mother is still there, and they try to apply the elastic wrapping and the delayed cord clamping and the nasal CPAP. And of course, do regular multidisciplinary stimulation training for familiarity and troubleshooting, and put posters in L&D and OR to remind the staff about deferred cord clamping. With multiple PDCA cycles, on a unit in UK, and of course UK, they keep publishing on each unit keep publishing their outcomes, and you can see once a unit starts implementing the cord clamp, you will see initial resistance and then a fluctuation, and this drop was basically due to a strike or something like that, and then at that point you will reach to your highest level of delayed cord clamping or deferred cord clamping more than 1 minute. And your immediate cord clamping rates actually drops with time, and keep doing this cycle until you have a persistent rates. And of course, if I talk here theoretically, initially when I thought of this one, I thought it's already khalas, it's already been studied, it's already been implemented. But by time we'll see it's really, if it's not documented, it's not there. And also in preterm infants, it's a challenge. It's a challenge and it needs expertise more. By this, I would like to conclude. Thank you very much. And this is the YouTube link to show you this, the baby trolley life, okay? Thank you very much.
Thank you. Thank you, Dr. Hundi, for being in time. May I call all the speakers to come to the stage for the questions, inshallah. Bring in time. Any question or comment? Okay. هذا الخير ولا شيء ما في. ما شاف حدا ما في يد ولا شيء. Yes, Dr. Sameh, please. Down in the down. Yes.
Assalamu alaikum. Good afternoon. Thank you very much for our distinguished speakers. My question here is addressed to Dr. Saif. Currently, what's your current practice, Dr. Saif, in minimizing or trying to minimize the risk of BBD in your institution? Currently, are you doing anything different to try to minimize out of the recommendations that you mentioned to us?
When I present my presentation, I thought, and I found myself that we are not using a lot of preventive measures for our babies. Example, Lisa. We don't start using Lisa yet. So maybe we are thinking together in the unit to start using Lisa. It may be helpful. We are using hydrocortisone for sometimes for babies in general. Mainly for small, tiny babies. We are not using it for a bigger baby, which shows the evidence that decrease the BBD, especially if the mother exposed to chorioamnionitis. And most of the preterm infants, they deliver early because of infection, prom, etc., etc. In regard to high frequency, it depends on the babies. We are not using it as a prophylactic, but if the baby is sick, we use it. Our rate of BBD, before I wish I have the slide, but I do not have it. It's comparable with which was in the literature. Maybe 28 weeker it reached 33%. For 23 weeker it's really high. Maybe it's 95% of the babies they develop BBD. It's in research, in process for publication of BBD in our unit.
I think, Dr. Saif, this is a national problem in all tertiary care centers within the kingdom. I think if we can take this opportunity from the SNS and have adapted a project to minimize the BBD across the kingdom by establishing clear guidelines that we can all participate, I think this will be a great idea, because I think all hospitals, what I know, and according to the best of my knowledge, all provinces, the middle, south, everywhere, we have the same problem. So I think, and as you said, Dr. Saif, correctly, most of us, they don't apply what we think it might help as to minimize the risk of BBD. Thank you.
Thank you.
Marcus, yes, Dr. Imran, please go ahead.
Assalamu alaikum. Thanks for the speak. Question to Dr. Mohammed Al-Hindi. Deferred umbilical clamp is not our problem, right? It's the problem with the obstetrician. I twice approached the head of department in 2 different occasions, and I gave him the recommendations and the guidelines. But it seems for some reason which we don't understand, there is no motivation on their part. We are convinced, in this lecture we are convinced of all the information you are giving, but how to convince the other side of the equation?
Thank you very much for this question. I usually take it as if you are from a different department, you're going to a head of another department and you're telling them something, they practice it. Of course they will fight back. I think the best way is to formulate a team with the stakeholder, like the midwives, the obstetrician. They should be taking the lead. And you just throw the information to them as a question. Saying, what about this? I heard something like this. Put it as a query for question for them to initiate, actually. And the other thing is the Saudi Obstetric and Gynecology Society. Where are they? I don't know. I couldn't find any recommendation from their side also. If their higher authority or a recommendation comes from their society, might be much more palatable for them. In such unit, I try to spread a culture. I tried to spread question. I said ابدا زي ما تقول انشر اشاعات يعني شايف انه في there is something called clamping, deferred cord clamping or something, at least to be aware. Maybe initiate a mini project like a small awareness project, a small video, a small webinar with CME hours, and things will take months, years until it's established. So even if we go to our center, if you ask the obstetrician, oh yes, we had a memo before 5 years about cord clamping, and I don't recall where is it now. And then they looked into the policy, the National Guard policies and guidelines, and they found one. Mashallah, it was in the eastern province, in Hassa. And I think definitely there is in Riyadh. So, these collaboration stuff, especially with medical complexes, because they are considered as a standard. You can tell them, oh, look, al-Haras wal al-Takhasus, they are standard this and this, so actually we should go ahead and... So setting standards, setting benchmark, publication, of course, this is the only publication I found about deferred cord clamping in Saudi Arabia. And eventually take it as a full bundle. Don't take just cord clamp and neuroprotection and etc. etc.
Yeah, just may I comment. In the last 2 months in our Medina National Guard, we are applying DCC. We make a CPG and then awareness for our colleagues in obstetric. Alhamdulillah, for the last 2 months they are cooperating with us so far. So hopefully, inshallah, we complete the study with them. Yeah, any more, please? Yeah, please.
Can I ask Professor Sajjad Abdurrahman, the program cell death in hypoxia, is it altered or changed by the hypoxia itself or other factor that death bring the cell death right away from 70 years into 7 hours or 7 minutes?
Yeah, I think the cell death is a combined effect of hypoxia and ischemia. So they both contribute to it. Okay. What we have learned is that the death is not instantaneous in most of the neuronal cells. The instantaneous death which occurs contributes a very small part to the neurodisability later on, or even to the death during the period. The major part of neuronal damage, including neurons and non-neuronal cells, it happens after birth.
Sure.
And that is where we as neonatologists are now working to say what opportunities we have once the baby is in the NICU. Then there is a lot of opportunity to save as much neurons as possible. And there's a famous article by Professor Marian Thoresen, Time is Brain. It's talking about the newborn baby. So the earlier you start, the better it is. The more you delay, the more is neuronal cell damage. Neurons as well as non-neurons. So these mechanisms are actually secondary and tertiary mechanisms, not the primary one. Primary, what we say is the hypoxia ischemia. It does damage, but that is not a big part of the whole picture.
But if it is started, if the program gets triggered by hypoxia, ischemia, or other factors, you cannot stop it after that, right?
No, that's what we think. Hypothermia actually stops that. The whole theory behind using hypothermia for 72 hours is that most of the secondary mechanisms which come into play after the first necrotic death of a few cells, these necrotic death cells release biochemical mediators. And these mediators then cause the cell death. So if we can stop the release of these mediators by giving hypothermia, then we prevent a lot of secondary damage. And that's where we think it is neuroprotective.
I think by this, thank you very much for all the speakers. Thank you very much for all the audience. We are going to now the speaker.
We are booked for the international speaker at 4 o'clock. And we have one lecture before that by Dr. Mansour Al-Qurashi. So please come back to the hall in 3:40 exactly, please. 3:40. So the next session will start at 3:40. And that will be the last session. So it will take you another 1.5 hours, and that's it. Thank you. Enjoy your coffee and come back soon.